So let's start coronary circulation or coronary microcirculation. Okay, how many basically different circulation in our body?
Two circulation.
Systemic and systemic circulation and pulmonary circulation, right? How to define systemic circulation? We have discussed in very detail in earlier lectures. Yes, didn't recall.
The circulation which covers all the major systems of the body.
Okay.
Or
Where it
starts
from and where it ends
in the heart.
and start from?
Heart itself.
Heart is the center in all type of you can say circulation. Okay, let me draw a figure. Fast. Okay, see this is you can say your venous. This is right side circulation. This is right heart. Hello, right, and this is your left hand, and this is also you can say representative. What? Arterial structure, right? This is your venous structure. And major artery, yes, bifurcated into medium, small, very small, then ultimately, yes, it capillary, capillary, and ultimately it break down into, you can say, capillary bed, right? And they reunite and make small venules, you can say reunite and make small size vein, small size, then medium size, then large size vein. Ultimately, drain into what you can say cable system, rather superior vena cava or inferior vena cava, right? So deoxygenated blood all over the body ultimately drain to cable system, rather superior vena cava or inferior vena cava, right? So yes. Let me complete the circulation. This is left heart, this is right heart, and in between that, here we have what? Yes, you can say respiratory system. I will draw. Okay, I will draw. This is single air pocket. This is another lungs, right? And here what? Right and left pulmonary trunk and bifurcated into right and left pulmonary artery. Suppose this one pulmonary artery bifurcate and break down into pulmonary capillary bed and ultimately reunite and ultimately make total how many veins? Total 4. You can say what? Pulmonary vein, which basically drain oxygenated blood into you can say left atria, right? So yes, now let's clear the concept about you can say systemic circulation and you can say pulmonary microcirculation. Pulmonary circulation. So according to you, you define that circulation start from the heart and end itself into heart. That circulation and which is cover the major system. That is you can say circulation, systemic circulation. But let's simplify and we will create very easy definition of the systemic circulation. Circulation in between left heart to right heart, which cover the you can say majority of the systems. These nourish and provide oxygen, hormones, and nutrients. That circulation, that major high pressure circulation is called systemic circulation. And the circulation in between right heart to left heart, that is, and which is only nourishing and providing blood to the or lungs or respiratory system. That small and low pressure system is called pulmonary microcirculation. And then we are coming to the you can say what coronary circulation that we are going to discuss today in detail. How to define coronary circulation?
The the circulation within the heart, for the heart,
Within the heart, for the heart,
and by the heart.
by the heart. Very good. It's like a definition of democracy. By the people, to the people.
The political acumen.
Yes, very good. And see, he was like instantly he created the definition. He was not, it was not planned, right? So very good. That means the medical concepts are clear, right? So suppose this is a heart, right? I am drawing the figure. This is heart. Okay, this is another heart. I am going to create a definition of the coronary microcirculation. The circulation from the heart, and you can a circulation within the heart, which is basically providing blood to the heart by the coronary artery. Yes, coronary artery, and basically it drain basically, yes, deoxygenated blood into heart by the coronary veins. This small circulation is called coronary circulation, right? So again, what is coronary circulation? Coronary circulation is basically circulation within the heart, which is basically supplied by the coronary artery and drained by the coronary veins, right? That circulation, close and small circulation, is called, you can say, coronary circulation. But it is very important, because if it is impaired, then major cardiovascular system or accident occurred, right? So that's all about, you can say, different definition of the circulation, right? Okay, how many coronary arteries are there dominantly? Main, you can say. Main are, I think, I'm sure, two, left and right coronary artery, right? So yes, let me draw a figure. Suppose this is our heart, right? And suppose this is atria, and somewhat here from left heart, what arise? Yes, from the left heart, what big vascular aorta, right? Suppose this is aorta, right? Ascending arch of aorta, and then after descending, right? Like that. So yes, and here what we have, you can say, which valve? Aortic valve, right? So it is basically aortic valve. Suppose this is in closed condition. It's not bicuspid, it's basically aortic valve. And just superior to the, you can say, aortic valve, there are three dilation. This is called aortic sinus also, or sinus of Valsalva. There are basically three, you can say, dilation like this. And posterior, you can imagine, right? So from the, you can say, left and posterior sinus or aortic sinus, basically which artery arise? Left coronary. Very good. So this is left coronary, right? Left coronary artery. And here basically you can say from the anterior, this is suppose posterior, and here is another sinus. From the you can say anterior sinus, basically another artery arise, and this is called right coronary artery, right? And in some case, basically from the posterior aortic sinus, some people, one more additional coronary artery arise and supply the heart. Even some condition, you can say, from the each sinus, two coronary artery basically giving to the heart, you can blood to the heart. So parallelly they are left coronary artery are basically two, and simultaneously they are basically traveling and supplying to the heart in same fashion. So it is in rare to rarest case, right? So dominantly more than 95% case or more dominantly basically we are having two coronary artery, that is left coronary artery and right coronary artery. So let's discuss about that. Initially we should start from the outermost topic. Let me clear it.
So you need to say in some cases there is posterior coronary artery also.
Yes.
In some cases.
Yes, in rare to rarest. I think you must have heard about the cardiac dominance, right? So that is a, you can say, condition. We are going to discuss that. But yes, basically coronary artery supply the heart from out to in fashion. So it will perfuse outer myocardium, middle myocardium and inner myocardium. And outer, you can say from the initial phase, coronary artery diameter is broad, and then after basically it bifurcate into small branches. So you can diameter become gradually, slowly. So it is very but obvious that it will nourish outer and middle myocardium very powerfully, but inner myocardium will be somewhat vulnerable compared to middle and outer myocardium. And yes, we know the physiology that during top of the systole, innermost myocardium is basically under high pressure, and practically during the systole, innermost myocardium are not getting blood. Practically, they are getting blood, oxygenated blood. You can say during practically from the relaxed period of the heart, that is diastole, right? That point we have already discussed in detail. So okay. These artery are called given name coronary. Why it is given name coronary? What is the meaning of coronary? Yes. In which language means? But coronary means it's like a crown of the king. Crown of the king. Basically, see. Okay, suppose this is the ventricle, left and right ventricle, right? And you can say on the top of the, or you can say head of the both ventricle, you can say coronary artery travels, and it looks like crown of the king. That's why they are given name coronary artery, right? So here basically these are the ventricle and these are, you can say, atria. Hello. And yes, there is groove in between atria and ventricle. That groove is called atrioventricular groove, otherwise horizontal groove, right? So this is basically groove, and basically coronary artery runs in this groove, or you can say sulcus, horizontal sulcus, or you can say atrioventricular sulcus. And in between in between right and left ventricle, there is another, you can say groove, and this is called, what should be the name of this groove? You can say this is anterior part of the heart. Can you say this is anterior interventricular sulcus, or simply it's called anterior longitudinal sulcus, right? So coronary arteries basically travel from here and here. You know the artery which basically runs and go down in anterior longitudinal sulcus. The name of the artery should be LAD, left. You can say left anterior descending, that we are going to discuss. Okay, and you can imagine that posterior part. See, this is anterior, then traveling left side, then you can say posterior and right side. There should be a posterior longitudinal sulcus, or you can say what? Posterior interventricular sulcus, right? Which artery runs, by the way, we are going to discuss, but that name of the artery is artery which runs downward in posterior longitudinal sulcus. Very good. Posterior descending artery. Posterior descending artery. Good. So here we have basically what aorta, right? Here we have aorta. Suppose this is the aorta. And it's arise, right? And suppose basically left coronary artery basically come here and arising. So we are what do you want me to discuss first, RC or LCA? RC. Okay. So from the you can say what anterior you can say aortic sinus basically what arise? Right coronary artery. Right coronary artery basically runs straight to the towards you can say right side of the heart in between atrioventricular sulcus, and you can say travel you can say backward. So I think if I should draw another diagram which demonstrating basically posterior aspect of the heart, right? Let me draw.
So, sir, this sulcus, the atrioventricular sulcus, is different than fibrous annulus.
Yes,
It
is innermost form circle. This is you can say they are the skin of the heart. You can say
surface.
Yes, surface.
Same with this longitudinal.
Yes. So this is anterior view, right? And now I am going to draw posterior view, right? So suppose this is posterior view will look like this, right? Is it okay? Suppose this is atria, right? This is sulcus, and this is what should be the name of this sulcus or groove? Posterior longitudinal, right? So see this RCA right coronary artery basically traveling throughout right side of the atrioventricular sulcus and basically go you can say posteriorly. So I'm going to this is the posterior end, right, and it will approach here. So this is the right coronary artery. Now it is approaching here, right? Suppose this is the branch of the RCA, whatever you give the name. This is what? Right coronary. Can you say distal coronary artery? This is proximal coronary artery, right? Yes. You can sharp angle. यहाँ पे एक और you can say branch of the right coronary artery arise and give you can travel straight downward and you can say supply to the you can say right free wall of the right ventricle. Free wall of the this is making you can say 90. So this is acute marginal artery. Acute marginal artery. Acute marginal artery, right? Okay. Here we have basically what? Posterior part of or distal RCA, right? This area making a cross, you can say cross of issue. Hello? So exactly, yes. And which artery basically runs here in posterior? Okay, this is posterior view. This is posterior view. Yes. Which artery runs here in, you can say, posterior PDA, posterior descending artery, right? So suppose this is artery, this is posterior descending artery, which is basically going down posteriorly. This is called posterior descending artery. So yes, you can say where posterior descending artery meet with the RCA, that area is called crux of the heart. Crux, right? It's called crux of the heart, right? Okay. Yes. Uh, one branch of the right coronary artery basically supply to the right atria, right? And in more, you can say 70 to 80% of case, right coronary basically supply SA node, right? Suppose we have SA node here. This is SA node, right? The SA node is basically supplied by the branch of the right coronary artery, and this branch should be given name SA nodal artery. SA nodal artery, right? And posteriorly, dominantly, I am discussing here. We should have another sinus that should be name of, what should be the name of this node? AV node. EV node. Not all case, but majority case, this basically AV node is supply. Okay, AV node dominantly basically AV node is supplied by the you can say branch of the PDA, posterior descending artery. And yes, what should be the name of this artery? AV nodal artery. So there is clinical, you can say, significant. But before discussing the, you can say, clinical scenario, should we discuss about the, you can say, left coronary artery? Hello. Okay, let's discuss the left coronary artery. So yes, we have a branch. Dominantly, we have a branch of the right coronary artery. Basically, you can say providing, or you can say giving supply to the right free wall of, you can say free wall of the right ventricle, that is acute or acute marginal artery, right? And another is basically SA-nodal artery and AV-nodal artery, right? Yes. Okay. I will discuss while I'm discussing about the, you can say, LCA. Okay. So right now, should I draw another diagram, or I should compensate in this diagram? Is it okay? Okay. So this, I am now compromising this diagram. This is our what? RCA, right? Keep up this. This is our RCA, right? Now, basically, now we are going to discuss about the left coronary artery. Left coronary artery. Left coronary artery, also called basically left main stem, LMS, or it is also called left main coronary artery. Left main coronary artery. These are same, right? Left coronary artery. So suppose this is the, you can say, left coronary artery arising from the, you can say, left and posterior sinus of the left and posterior aortic sinus, and it travels initially, you can say, 10 to 25 millimeter, and then it bifurcates into two branches. One branch basically go and directly travel to the, you can say, left side of the atrioventricular sulcus, and another branch basically travel, you can say, in longitudinal, anterior longitudinal sulcus, right? And it will then travel posteriorly. Hello, am I making sense or not? Right. So here we will have which branch? Okay, what should be the name of this branch of the left coronary artery? LCX, right? Left circumflex artery. You can say it is traveling throughout, right? So it is called left circumflex artery. Left circumflex artery. Left side circumflex artery basically give a straight downward branch of the artery which is supplying basically what?
Free wall.
Free wall of the left ventricle. It is called again obtuse marginal artery. Obtuse marginal artery, otherwise you can say marginal artery. Left marginal artery and right marginal artery. So you can say LCX is basically supplying, you can say, left part of the, you can say mainly left heart and branch of the LCX. This is obtuse marginal artery. It is providing the, you can say, left surface of the left ventricle, right? Here we have another branches. Okay, this is LCX, right? LCX, and this artery is called, yes, what should be the name of this artery? This is yes, left anterior descending artery. Left anterior descending artery. Otherwise, can you say this is anterior interventricular artery? Anterior interventricular artery, and you can say atheromatous plaque and related complication cause majority in LAD. Atheromatous plaque in the LAD cause, you can compare to another artery, cause, you can say death of ratio is high. That's why it is also called widow-maker. So left anterior artery, we have three names: left anterior descending artery, then yes, anterior interventricular artery or interventricular artery, and third is widow-maker. Occlusion of these LAD generally, like majority case, death cause of the death is basically LCX occlusion. That's why it is called widow-maker artery, right? And yes, LAD is having another branches. Suppose this is branches. Yes, anyone idea of this artery? You can say branch of the left anterior descending arteries. This is called diagonal 1 artery and diagonal 2 artery. Diagonal artery, right? Okay. Diagonal artery basically supplied, you can say, lateral apical bag of the left ventricle, right? And also it meets inferior wall of the heart, and it meets and make anastomosis with the, you can say, branches of the posterior descending artery, because posterior descending artery, as it is coming like that, right? And here what branches of the LAD, and you can say diagonal 1 and diagonal 2 are basically branches of the LAD, right? So it basically go downward inferiorly and make anastomosis with the, you can say, PDA, right? But anastomosis process is very small, and you can say very number of, you can say number of anastomosis anastomotic arteries very few. That's why they cannot prevent, you can say, infarction. Ideally, if two arteries are involved, then if one is occluded, then another should be nourish the, and you can say meet the demand of the oxygen and blood. But we have clinically seen there are clear-cut myocardial infarction due to you can say occlusion of the one particular artery. So there is anastomosis, but that is not that effect that so much effective, right? Okay, so this is LAD, left anterior descending artery, and branch of the left anterior descending arteries, diagonal 1 and diagonal 2. And yes, okay. This is LCX, right? And what is this in between left and right ventricle? Interventricular septum of the heart. And yes, there is a basically, you can say, up to 90-degree coming one artery, branch of the, you can say, proximal LAD, hello, and which is supplying to the, you can say, anterior 2/3 of the heart, septum of the heart, anterior 2/3 of septum. That branch is called obviously septal artery. Hello, septal artery. So how many branches of LAD? Septal artery, diagonal 1 and diagonal 2, right? Right? Or you can say these all are the branch of the left main coronary artery, right? So left, you can say, yes, septal artery basically supply anterior 2/3 of the interventricular septum. Then what about the 1/3 posterior? Here 1/3 posterior septum of the interventricular septum. Yes, that depend, but there will be you can say at this place a new concept will come, that is called coronary dominance. Yes, in echo, or no, not echo, in angiography. In angiography, we sometimes read that patient is basically left dominant and right dominant, or sometimes that in 1 to 2% co-dominant, right? So what is that meaning? So here we have which artery? LCX. Hello. So LCX coming here from, then LCX is coming basically running in, you can say, posterior atrioventricular sulcus. So this is another branch of the diagram is somewhat messed up, but that's fine, right? We can understand. Yes, in see, this is posterior part of the you can say left heart, right? So yes, from the LCX here, from here one more artery come and go down, right? This artery should be given name what you can say posterior marginal artery. Hello, right? Posterior marginal artery, right? Now let's discuss about the coronary dominance. What is coronary dominance? That coronary dominance is basically depend which artery basically supplies posterior descending artery. See, coronary dominance. So yes, if right coronary artery basically supply this posterior descending artery, this is called right, and in this condition we will call the heart is right dominant, and you can say up to 70% of case heart is basically right dominant, right? And if you can say LCX basically supplying posterior descending artery, then in that case we will call it left dominant heart. left dominant heart, and this is we can see into 10% of case. And RC and LCX both are basically supplying to the posterior descending artery. In that case, we'll call it co-dominant heart, co-dominant circulation. And we practically we see 20% of case co-dominant heart, right? So yes, it will depend. See, which artery is basically supplying to the posterior descending artery. It will basically create the you can say coronary dominance, right coronary, left coronary, or co-dominant, right? See, let's discuss about the clinical scenario. See, here we discuss that in 70% case of right coronary artery supply basically posterior descending artery, and posterior descending artery basically supply what? AV nodal artery, and proximal you can say RCA also supply SA nodal. So in suppose we have a basically coronary artery disease patient and having atheromatous plaque in you can say proximal coronary artery. Proximal coronary artery is having basically what? Atheromatous plaque, right? What will happen? That little trickling blood is basically enough to you can say supply the blood to the right ventricle, because right ventricle is very thinner and it is dealing with the low pressure system, right? So there is low oxygen demand you can say system. So critically occluded proximal RCA can meet the demand of the right ventricle. So generally we don't see the right ventricular infarction, right? More than 95% case we see basically what? Left ventricular infarction, right? So what will happen? Patient, see, little trickling blood will you can say nourish right ventricle properly, but what about the distal area? And most distal area is basically what? Posterior descending artery. Posterior descending artery PDA is basically supplying to the posterior and basal part of the heart. That is called posterobasal. Hello, posterobasal part of the heart. Posterobasal part. So see, as we discussed, we have a dominantly you can say right dominant heart. So I will discuss according to that. So if RCA is blocked, then chances of developing of myocardial infarction is generally posterobasal or inferior wall MI.
Yes.
And there is high chance in generally what happen in myocardial infarction sympathetic nervous system is augmented, and what happen sympathetic nerve fiber release extra neurotransmitter SA nodal and AV nodal basically, or you can say stimulated positive chronotropin, you can say dromotropin, heart rate should be goes up in dominant you can say myocardial infarction. But there is high chance in you can say inferior wall MI, otherwise posterior infrabasal MI. There is high chance that SA nodal artery and AV nodal artery will also get lesser blood.
Yes.
And there is chance it will get ischemia or infarcted. So in that case, there is high chance we will see sinus bradycardia in inferior wall MI, other posterobasal MI.
Yes.
In right, 6 sinus syndromes or sinus bradycardia, or can we see you can say nodal block. So patient may with the classical sinus symptoms of the MI with heart block, maybe first degree, second degree, third degree, depend upon the you can say injury to the AV nodal heart and even sinus bradycardia. Am I making sense or not? Very good, right? So this is a classical sign. If patient come with a classical sign and symptoms, you do 12-lead ECG. You see, if you even you suspect the patient, you have not done ECG, but you are clinically judging a patient is having classical sign of you can say cardiac event, and ideally during chest pain or you can say anxiety, heart rate should goes up. but you see a heart rate is going down, then clinical science should tell you that if patient is having MI, then MI should be which wall? It should be posterior wall MI, otherwise in posterior-basal or inferior wall MI, right? Very good. Okay, we discussed the one point here. We discussed that you can say branch of the, you can say proximal LAD, that is sternodal artery, sorry, septal artery, my mistake. Septal artery basically supply to the anterior 2/3 of the septum, and yes, from here basically branch goes and it basically supply posterior, you can say 1/3 of the posterior, 1/3 of the septum, posterior 1/3 of septum.
Distal axis.
See, here we have to, if basically artery is proximally occluded, distal area will you can suffer more, because we see supply is cut off or compromised, the distal area will get affected first. Right? अपने वो पानी में, अरे खेत में पानी डालते हैं तो इनिशियली क्या होता है कि यस लास्ट में जो होगा वो उसको पहले बंद होगा, इनिशियली तो विल कंटिन्यू गेट. Okay, that was the one topic. Now let's discuss about the if patient is having basically initial proximal LCA, left main coronary artery is occluded, critically occluded, and in that case basically what will happen, that septal artery will get lesser blood, then what, this LAD will get lesser blood, and you can say in this LCX will also get, then patient will have basically you can say extensive myocardial infarction. It will cover the anterior part of the heart, lateral wall of the heart, and even basically septal wall of the heart, right? So in that case we will have a, you can say large anterior, or you can say large you can say anterolateral wall MI having also septal involvement, right? We see so many cases. There we have a from V1 to V6 ST segment elevation, and we know V1 and V2 are which leads? Septal. V3 and V4 are localized anterior leads. V5 and V6 are basically, that is precordial lead, right? V1 to V6, and in horizontal plane basically 1 and AVL are also lateral leads, right? And 2, 3 AVF are inferior leads, and what else? AVR basically looking into right atrium. From here, AVR is at the, you can say minus 150 degree, right? And straightly looking into right ventricle, right? Okay. Second possibility, if patient having basically atheromatous plaque in this area, and hemodynamic event occur, and this you can say LAD is complete occluded. In this case, what will happen? Patient will develop large anterior wall MI with septum. In this case, basically patient will develop anteroseptal wall MI, and changes you will see in V1 to V4. Am I making sense or not? And yes, what if patient is having, you can say proximal or middle? Okay, so middle LCX is basically critically occluded. So in this case, septal artery will get very good blood, but distal part of the heart will, anterior part of the heart will not get blood, and in this case basically patient will develop, you can say localized anterior wall MI, and the changes you will see in V3 and V4, but it is extending, then V2 and V4 also, V5 will also get in, you can say involved. In that case we will see that is large anterior wall MI. If we see ST segment elevation in V2, V3, V4 and even V5, that suggests it's not localized, large anterior wall MI, right? And yes, here we have basically classical, you can say, theory. Diagonal branch of the LAD basically supplied papillary muscle. You know, papillary muscle attached with the, if we are talking about the left heart, then papillary muscle is attached with the what? Which valve? Mitral valve. Left heart atrioventricular valve is, left sided atrioventricular valve is mitral valve, and mitral valve is supported by what? Papillary muscle, and heart is basically rotated leftward and anterior. So basically anterior and lateral papillary muscle is supplied by the diagonal artery, and diagonal artery is a branch of LAD. So LAD is occluded, and in patient will develop anterior wall MI, and in that case papillary muscle will also get affected, and there is chance that mitral valve will dysfunction, and there will development of mitral regurgitation. So sudden mitral regurgitation along with the anterior wall MI, that you must be clear that LAD is occluded, right? Basically, suppose this is mitral valve. So this is two leaflet. So this is you can say yes, left and posterior leaflet, and this is basically what anterior. Sorry, my mistake. This is left and anterior leaflet, and this is basically left and posterior. Sorry, posteromedial. This is medial side, medial and posterior. The posteromedial leaflet. So you can say left and anterior leaflet of the mitral valve which is supplied and which is basically the chordae tendon is attached or papillary muscle is this papillary muscle is basically supplied by diagonal artery, right? Diagonal artery, and this is supplied by the, you can say, branch of the RCA, right? Yes, we should not forget that L6 will basically supply to the what? Left atria by the atrial artery, right? Branches of the. So we can understand that, right? So anything else we are missing? See, okay. This is basically apex part of the heart. So if distal LAD is basically involved, patient will develop apical wall MI, and specifically sensitive lead for the apical area, left and apical area is V5 and V6, and in that case basically patient will have ST segment elevation in localized V5 and V6 if distal LAD or you can say diagonal 1 and 2 basically affected. But specifically if LCX is blocked, like here, the patient will develop basically, you can say, lateral wall MI, and in specific case, patient will see ST segment elevation in 1 and AVL. But if proximal LCX is occluded, then this area branch will also get affected, and in that case, you can say specific lateral and apical both branch will affected, area will be affected, and you will get ST segment elevation in V5 and V6. So depend where basically atherosclerosis plaque or thrombus is, you can say, occluded. Am I making sense or not? Is it clear? So let's discuss about the involved artery, and you can say ECG leads and its territory, right? Okay, let me discuss randomly. I'm not going to write down the territory of the RCA, right coronary artery. Right free wall of the free wall of the right ventricle, then SA nodal artery, SA node, AV node, then posterobasal part of the heart. Yes. Then what? So these are, and you can say right atrium, right atrial. So these are the territory of the RCA. And what are the basically territory of the LCA? Then yes, obviously septum, anterior wall and lateral wall. And if left dominant is, then it is posterobasal. But we are talking as a patient is having right dominant heart or the circulation, right? LAD, specifically LAD, territory of LAD is basically left anterior descending artery territory is basically anterior 2/3 of the septum, then anterior wall, then apical part, and some up to some degree you can say inferior part of the heart. Am I making sense or not? Okay. Then what is the territory of LCX? So left free wall of the left ventricle, you can say heart. Then posterior wall of the left marginal part of the left ventricle. Hello, right? And yes, left atrium. This is the territory of, you can say, LCX. Is it clear? Am I making sense or not? Any question? Do you want me to repeat this concept? Hello? Clear? Okay, let me clear it. Fast.
This the diagonal 1 and 2, they are also called OM1 and OM2.
That is obtuse marginal artery. Yes. No, that is the diagonal for D. Okay, let's discuss about the ECG, 12 lead ECG, and it's basically which leads represents which area. So okay, here we have ECG leads. So okay, ECG leads V1 and V2. V1 and V2 basically represents septum, right? So you can say part of the heart. Hello, involve part of the heart, and this is, you can say, septal. And yes, okay. Now imagine you have a typical septal wall MI, and then you will see ST segment elevation in V1 and V2. Then which artery should be ideally occluded? Proximal? My God. LCA. We have proximal LAD. Should I draw diagram here again? So should I draw or not? So this you can say involved artery. Involved artery should be, yes, proximal LAD. Very good. Proximal LAD, right? And yes, you have a localized ST segment elevation in V3, V4. Then basically that should be anterior part of the heart, that is anterior wall MI. And in this case, yes, which artery should be involved? Again, proximal LAD. Yes, you can say proximal LAD, but basically crossing the, just, can you say just below the branch where basically LAD is giving to the septum branch, that is septal artery. Again, this is initial proximal artery, right? So yes. or simply you can say LAD, left anterior descending artery is involved. And yes, again you have a basically ST segment and elevation having V5 and V6. Ideally, which artery should be involved? Very good. Distal LAD, and branch should be affected. Branch should be diagonal 1 and diagonal 2. And here you will see apical wall. Hello, right? Here you will have a apical wall MI. That is apex area, right? And basically, yes, involved arteries basically very good. Distal LAD. Conceptually, I think you people are clear, right? And yes, then you have a basically ST, you have a myocardial infarction, and you see ST elevation in 2, 3, and AVF. Then MI should be named as a inferior STEMI, right? Inferior STEMI. Inferior STEMI. And yes, ideally, involved artery should be RCA. RCA. Posterior descending artery. RCA. Proximal artery. Very good. Proximal artery. Proximal RC. Very good. Can you imagine this? How it is happened? Very good. Then proximal RCA. Then yes. Which type of MI we are left with? Postrobasal, right? Then you have postrobasal MI. Postrobasal MI. Yes, that is posterior wall MI, right? So ideally, which are the classical you can say parameter to diagnose the posterior wall MI? In 12 lead ECG. Reciprocal changes in V1 and V2 and up to some degree V3, right? And you can say posterior, you can say reciprocal changes will seen in right sided and up to anterior lead, that is V1, V2 and up to some degree V3, and it will show reciprocal changes, that is ST segment depression. So patient is having typical sign and symptoms of cardiac event, and you do ECG and ECG showing ST segment depression in V1, V2, then it's a basically sign of posterior wall MI. And if you are not basically sure and you want to make sure that yes, patient is having posterior wall MI, then you will put additional lead that we have discussed, right? That is V7, V8 and V9. You people know what are the placement area for that V. So okay, I'm fast repeating. V1, right parasternal, fourth intercostal space. V2, left parasternal, fourth intercostal space. Then V4, mid axillary line, fifth intercostal space. Then V3 in between V2, V4, midway between V2 and V4. Are you recalling or not?
Yeah.
Then V5, that is, this is axilla, and axilla is having three parts: anterior axillary line, mid axillary line, and posterior axillary line. So location for the fifth intercostal, V5, that is anterior axillary line, fifth intercostal space, V5. V6, mid axillary line, fifth intercostal space. Now if you want to diagnose posterior wall MI, then you put three additional leads, that is V7, that is posterior fifth intercostal space, posterior axillary line. Why are you laughing? Am I going?
I recall myself being naked for this. I removed my shirt for this practical in the Bali center.
Okay.
I recall.
But I cannot. I am the case of short memory loss. So V7, that is what? Posterior axillary line, fifth intercostal space. Then location for the V7, that is inferior border of the scapula, just inferior border. And V9, that is, you can say paraspinal, and you can say left side, you can just near to the paraspinal area, near to V8, right? And you see ST segment elevation, then you will label the patient is having posterior MI, right? Yes. So can you say we ideally, if we are talking about the STEMI, then we will have a ST segment elevation in V7, V8 and V9. Hello, right? And what should be the ideally involved artery? Oh, that is not necessary. Initially, basically, ideally, see, practically discussing, proximal artery develop more atheromatous plaque. So, involved artery should be, it may be, see, let me, that is RCA, it may be proximal or distal, and yes, what else? See, anastomosis, PDA meets with the branches of the left anterior descending artery. So there is high chance that diagonal or you can say distal LAD should be involved. Hello. So can you say distal LAD? Right? Is it making sense or not? Sorry.
RCA માં પ્લાક ન હતી ખાલી ડિસ્ટલ એલઈડી માં છે તો પણ એ ચેન્જીસ આવે ખરા
Not significant. Patient will develop you can say apical, more apical sign and symptoms of apical wall. But if more than 2 arteries is involved, then atheromatous plaque should be here and here also, right? And see, okay, if we see anteroseptal wall MI, then you can recall. So, let me draw another. This is your left coronary artery. Hello, and then it bifurcate. This is LCX. Hello. Okay, this is left coronary artery. Okay, let me draw a diagram first. Left coronary artery. Then what else? This is anterior descending artery, and here we have straight 90-degree going septal artery, right? So this is left main coronary artery, this is LCX, this is LAD, and this is septal, right? So yes, as I discussed, if atheromatous plaque is here, then patient will have extensive myocardial infarction. Hello. That it will include lateral, anterior, and even septal part of the heart, right? If patient is having atheromatous plaque here, okay, let me draw in 3 dimensions. In this case, patient will develop what? Anteroseptal wall MI. Anteroseptal wall MI. A patient will develop atheromatous plaque here. Sorry, my mistake. Then patient will develop anterior wall MI. And if patient develop atheromatous plaque in you can say distal LAD, then patient will develop apical wall MI. Hello. And if proximal LCX is basically occluded, then patient will develop anteroapical, that is typical lateral wall MI. That you can say LCX, which is supplying to the lateral wall and obtuse marginal artery, which is providing basically left surface of the left ventricle. Then patient will develop what? Lateral wall, right? This is RCX, LCX, right? And what is here basically? This is obtuse marginal, right? Obtuse marginal artery. And if basically here is atheromatous plaque, then patient will develop typical lateral wall MI. Distal LCX is involved. Am I making sense or not? So this is how we can can say predict which artery is involved by basically you can say diagnosing the which wall MI is there. Any question? Is it? Yes, please.
This distal LAD, if distal and LAD is occluded, only the apical part will be affected and not the anterior part.
Yes. If distal is there, then anterior wall will be, you can say, supplied by the, you can say, proximal LAD, right? But distal somewhat here, then apical part will be affected.
And if it is right below the septal junction, then anterior also.
Yes, this will yes, it will you can say involve anterior wall and plus maybe
Plus the-
anteroapical. Hello, right? Is there any question? So that's all about the coronary circulation, its branches, and correlation between which wall MI is there and you can say probably which artery is involved. You can say very logically, right? And we don't need to discuss about the coronary veins. Basically, small veins drain into very small vein, drain into small vein, then small cardiac vein drain into middle size vein, middle size cardiac vein basically drain into greater cardiac vein, and greater cardiac veins ultimately drain into what? Coronary sinus. And coronary where coronary sinus is exactly available situated in the posterior wall of the right atria, and then basically coronary circulation will drain deoxygenated blood into right atria. Right atria will drain blood into right ventricle. Right ventricle will push blood into pulmonary microcirculation, and that blood will get oxygenated, right? And this will go on up to you leave, right? So, is it clear?
I have a question.
Yes, please.
What occludes PDA, posterior descending?
What occlude?
I mean, which part, like, if it is affected, PDA is
See, dominantly RCA, but yes, there is chance if distal RCA's occlusion is there, then PDA will affect it. Even you can say proximal PDA is localized atheromatous plaque is there, then patient will develop, yes, definitely posterobasal MI. So occlusion may be there, but we should have a logical idea which areas can be affected, right?
This can be written here or not? In posterobasal, PDA, occlusion.
Okay, localized PDA you want me to write? Okay. Localized PDA. Okay, happy? So, done? Okay, fine. Class is